It's recording. It's recording. Just leave it on the table. It'll be good.
Can I show the glass?
I'm going to cut it all out. So everyone got the handouts? What I want to do is I want to go through the patient assessment, right, and how it's pertinent for you in terms of ALS care. Then we're going to go through the treatment specifically for your tachyarrhythmias, stable and unstable, ventricular tachycardias, right? And I'll show you the actual medications, how we infuse it, so that you have an idea, right, what you're going to do once you're in the field. So when we start our patient assessment, if you have this sheet, we're going to pretend this is our patient. For this call, let's pretend you're called for a 65-year-old male patient to a home residence, right? And he's having significant chest pain, and you could sit here like clutching your chest, right? So first, you're going to get dispatch information when you go to your station. So you're dispatched for a cardiac call or chest pain or anything like that. Your entire patient assessment starts with scene size up, right? So you're going to say, right, BSI, right, my scene is safe, but some instructors will have you actually go through it, like you actually take corrective measures, right? You'll say, I put my face protection, eye protection, gloves, look at the surroundings, right? There's no hazards, there's no barking dogs or anything like that, right? So some of them will go through the steps. I determine my nature of illness, which will be a cardiac condition. I have one patient. Since I'm an ALS provider, I'm going to come in with my partner. I don't need any additional resources just yet. I'll call them if I need them, right? And I'm going to bring my C-spine equipment with me to the scene in case I need to stabilize the cervical spine once I see them. So scene size up is prior to you making patient contact. Everybody follow? Right? So now we arrive on the scene. Let's say someone lets us in, right? We come inside, and I'm going to form my general impression. General impression basically tells me, is he sick or not sick? This is not repeat of dispatch information. So you don't tell me, we got a cardiac condition, right? What you're going to say is, I see a 65-year-old male. He appears to be sitting on the sofa or a chair. He's clutching his chest. This is called the Levine sign, right? It's very pathognomonic of some sort of acute coronary syndromes. So that's your general impression from the viewpoint when you come inside. Next thing what I'm going to do is I have to determine if he's a reliable historian, right? And obviously I don't see any trauma here, so I'm not going to protect his spine. I'm not going to stabilize his head. So the reason why I got to get his mental status next is I have to know that whatever he's telling me is correct information, one. Two, if he decides at any point, he says, I don't want to go to the hospital, I want to, stay home. I know he's a reliable historian, and he is capable of making such decision, right? So I'll come in, there's 3 identifiers. And what I like to do is say, hi, my name is Nikolai, I'm a paramedic, what is your name?
My name is Milan.
Milan, right? Can you please tell me where you are right now?
I'm home.
Home. And what year is it?
2022.
2022, right? Notice I did not ask him, do you know where you are? Because he will say yes. Do I able to assess that? No. Right? So you want to ask him, can you please tell me where you are? And notice I didn't ask him for the date. Because if you ask me for the date, and if I work night shift, day shift, I don't remember myself, right? Do I look altered to you? Probably not, right? But if you ask me the year, right, I can tell you the year. Also, don't engage into like who is the president, who is the mayor, who is whatever, right? You don't want those side conversations. You want to establish, right, his name, location, and the year, right? 2022. The next thing I want to get is chief complaint. Why are you here, right? So you'll say, Milan, what is the reason you called the ambulance?
I have chest pain.
Okay, so that's basically he's telling you what it is. Maybe sometimes the family members call the ambulance, so you'll ask why did they call, right? And they will tell you the information. So he's a reliable historian. We determined that. His chief complaint is chest pain. Next thing we're going to go through is ABCs, right? Airway, breathing, circulation. I want to ask you this question, right? What is the difference between when we go through ABCs versus you guys learned in your AHA assessment, right? When you learn AHA BLS, you learn CAB. So what's the difference?
Conscious versus unconscious.
Conscious versus unconscious? So unconscious, unconscious you get CAB, unconscious you get ABC?
No, CABs, compressions, airway breathing, ABCs, airway breathing, circulation.
All right, so Milan knows because he already had this before, right? You already heard it before. So what I want to ingrain in your head, it's always ABC, always, right? What is CAB? C stands for compressions. So the moment you determine there's no pulse, you're going to initiate compressions first. This is basically an algorithm, right? So all your patients are going to be assessed ABC, regardless if they're conscious or unconscious. However, if I come in and I say, hello, my name is Nikolai, what is your name? He doesn't respond. I do a painful stimuli, no response, he's unconscious, right? I check my pulse. There's no pulse, I'm going to commence with CAB because I'm going to commence with compressions first. Make sense? Right? But your assessments always follow this ABC mnemonic, right? So now that I'm going to check his airway, how do I know airway is clear and maintained? Is A, he's able to phonate, he's able to make sounds, he's able to talk to me. So I know it's clear. But we also have to determine if it's maintainable by himself or by his own volition, by his own accord. How do I know that?
He swallows.
He swallows, excellent, right? So you could ask him, can you swallow? Because you may go to a nursing facility, patient may be alert talking to you, but they cannot clear their secretions. They have secretions pooling, so they're able to talk to you, right? They're able to have a patent airway, but they're not maintaining it. Because if I let this person go, right, they may now aspirate, right, and I have a potential airway compromise. So because he's able to talk to me, I ask him to swallow. I will say my airway is clear, patent, and it's maintained. Yeah? The next thing we're going to do is a breathing component, breathing assessment, right? So for here, for National Registry, what you can do is you can actually put a pulse ox to get his saturation at room air. So you notice I didn't give him oxygen. I'm going to put a pulse ox. I'm going to start getting, right, my waveform. Per the American Heart Association, right, per the AHA, so let me raise this. Per the AHA, right, if you have acute coronary syndromes, right, ACS, you would want to give oxygen if your saturation is less than 90%. If you have a CVA type condition, right, you would give it if it's less than 94. This is per the American Heart Association. So I'll explain what that means. So if he's having chest pain, right, that's his chief complaint. We're only going to give him oxygen if it's less than 90%, right? I should put it like this. Less than 90%. If he is at 90 or above, I'm not going to give him oxygen. Why? Because they did studies, they said that there's possible free radical damage, and in those conditions, CVA and acute coronary syndromes will cause more harm by flooding them with high count O2. Right? So if he's setting 89%, I'm going to place him on nasal cannula. Right? If he's setting above that, I'm not going to provide him oxygen. But before we're going to go to oxygen therapy, right? We're still getting the readout. I want to check his breathing status. I want to do a breathing assessment. And a good mnemonic for you guys, if you want to write this down, is it's doctor, like medical doctor, right? Dr. Q, right? DRQ. So what is all this, right? So D stands for depth, R stands for rate, and Q stands for quality. Depth, right? Rate, quality. And so what I mean by that, depth. Normally we take our tidal volume breathing. Tidal volume is roughly 500 ml, right, of for a normal person. So I'm going to look at his chest from the side. I'm going to see if he's taking deep breaths. So do I have increased tidal volume breathing, right? I have deep breathing. Do I have normal breathing, or I have shallow breathing? Then I look at the rate. I usually do 15 seconds times 4 to give me a quick number. I'm not per se trying to get like an accurate rate per se. I want to see if there's any life threats that I need to address. Quality. Do I see accessory muscle use? Is there nasal flaring, retractions, right? Intercostal muscle use. Do I see him sitting right upright and forward? Do I see pursed lip breathing? Is he laboring to breathe, right? That's what I want to assess. Now, here's a question for you guys. If a person is, right, conscious or unconscious, does that dictate do they get BVM or not?
Nope.
Can a conscious person receive BVM ventilation?
Yep.
Yeah. And why would they receive ventilation?
Not adequate to sustain life. It's
Well,
too shallow. Or
excellent, right? So you would say, yes, a conscious person may receive if their depth is shallow, right? Maybe they have high elevated rate and we see accessory muscle use. And certainly we use a pulse ox to see, right? Maybe they're also not saturating well. So now I look at his depth. We're going to say his depth is adequate to sustain life. He has increased rate. For this case, we're going to pretend he's breathing at a rate of 24, and he has some accessory muscle use. I look at my pulse ox, right? Room air, it's 100%. So I'm not going to give him any oxygen, right? Because if he's saturating at 100%, there's no need to that, right? So good mnemonic, right? Dr. Q, depth, rate, quality. This determines how you give oxygen, nasal cannula, non-rebreather, BVM. And it tells you if your patient's sick or not sick in this case, right? Next thing, we're going to go into circulation, right? Circulation has a couple of things. First, I want to determine if there's life-threatening hemorrhage. What I do not ask him is, sir, are you pissing blood, right? Is there blood coming out of your stool, right? The purpose of this assessment, let me just scroll up on this to show you, assesses major bleeding, right? So I'm gonna say, I'm gonna observe him, and I do not see any life-threatening hemorrhage, right? I don't see he's bleeding profusely. You could ask him, sir, are you bleeding anywhere? If he says no, I'm gonna leave it at that for the medical call. Any of you went to ALS rotations, right, for chest pain? Have you seen medics ask, are you pissing blood? Is there blood in your stool? Right? They're probably not going to ask that, right? Even in your clinicals. So don't ask that. Next thing we got to do is check his pulse, right? I check the radial pulse, 15 times 4, get a quick number. If the radial pulse is not there, I could check brachial, right? And then you check a central pulse, a carotid. And then we got to check skin color temperature condition. So if he's warm, dry, right? Not diaphoretic here. You could check conjunctiva, right? Pink underneath here, right? So for the circulation component, right, we want to determine basically if he's in shock or not in shock, right? Make sense? So this is your ABCs. One thing I want to show you how to assess long sounds. Long sounds we assess in the breathing component. I'm just going to have you stand up because I see you guys when you're checking long sounds, you're checking kidneys, right, and some other things. So first, what you want to do is ask your patient to hug themselves. Why? Because it stretches the scapula. Now unhug yourself. You see how they retract, and now hug again. See how they retract? Here, right, is where you're going to listen to your lung fields. Here is where your kidneys are, right? So what I want to do is when I'm listening to the lung sounds in my breathing component, I'm going to start from one side. He's going to take a deep breath. Don't stand in the front, stand in the back, and ask him, open your mouth, take a deep breath. Then I go to the other side and I compare. Deep breath. Good. I go down. And then I do mid-axillary. Right, mid-axillary. So you don't have to take a deep breath. I'm just showing you the pattern. 1, 2, 3, 4. You could go down here if you want to, and then you go into the side, right? You could check the APCs, but for the primary assessment, right, I really want to know what's going on to the bases and on each side of my lungs. It gives me a good idea, because if he has rails here, right, I know, right, it's pulling, it's gravitational, right, so they're going to be towards dependent fields. And that determines, right, if the lung sounds are clear or not clear. So then you will say, right, I hear crackles, I hear wheezing, it's clear, or whatever the sounds are, right? Make sense? Please, just while you're here, please do not listen to the lung sounds here. Okay? And don't listen to the lung sounds here because you're not going to be able to hear much at all, right? Clear? All right, thank you. Right? Yeah, I did not put the stethoscope in my ears. It's his stethoscope. I know you don't hear any lung sounds by having your stethoscope, just you guys know, right? You're not going to hear anything. Actually, I was working in a place where I saw a doctor doing rounds. He would be like to the patient through the sheets and the bedding. Oh, good. You're doing very good. All right, so don't do that. All right. So now we're gonna make our decision, right? Don't say stay and play, load and go. That was like your EMT stuff, right? Here we're gonna say high priority patient, right? It means expeditious transport. We're gonna stay and do further assessment. So high priority patient, right? You want to expedite the transport, or you're going to stay and do further assessment. Example, I have someone with isolated radius ulnar injury. I'm going to stay on the scene and splint, maybe give some pain management. Someone with chest pain, I don't want to stay on scene. I want to, expedite transport. So now we finished our primary assessment. We get to the secondary assessment. And then the secondary assessment, there's a couple of key components that you want to be familiar in terms of ALS. The order doesn't matter. I personally do have a preference when I do it, and I'll explain to you why. So first, I like to ask the history of present illness, right? This is the reason why you're here. And the history of present illness for chest or respiratory condition is O, P, Q, R, S, T, I, right? So this is a history of present illness. Why are you here? So O is onset. And onset is not when did this start. Onset, was this gradual or was it sudden? So I'll ask him, did this chest pain came on gradually, or was it sudden onset? Did it came on suddenly? Right? Why is this important?
When you're doing a differential diagnosis.
Excellent.
Yeah.
So he's saying differential. So how's gradual versus sudden help me with my differential?
If it's something like pneumonia, it might be gradual. If it's acute coronary syndrome, it might be sudden.
Excellent, right? So what he's 100% on the money, right? So what he's saying is this, right? If let's say it came on suddenly, let's say he's complaining of sudden tearing pain behind his shoulder blades, and then he got chest pain. So I'm already starting to think maybe he has aortic dissection or something along those lines. But he says, okay, I was stacking boxes, right, doing some housework, and all of a sudden I had this heaviness starting to develop over time. So it gradually came on. So I'm now not thinking about aortic dissection, right? I'm trying to see maybe it's ACS, maybe it's angina, right? That's unstable or something along those lines. Another example of sudden could be severe chest pain, sharp, right? And all of a sudden, patient is saturating very poorly. You give them 100% oxygen, saturation doesn't come up. And they say, oh, I have pleuritic chest pain, came on suddenly. Maybe they have pulmonary embolus, right? Large sudden onset, right? So this tells me, right, in terms of differentials, right? Then provocation, you would ask them, does anything make it better or worse, right? So if they say physical exertion makes it worse, or resting makes it better, or I took my nitroglycerin, made it better, so that, again, helps your differential. Then we say quality. Don't put any words in their mouth. Don't say, is it sharp? Is it dull? Is it like that? Just say, can you please describe the pain you're feeling, right? Sometimes they're not going to even use words. They'll sit there like this and showing me like clenched fist. That's their feeling. And that to me is very good because I could see what the patient is telling me, right? Sometimes it's nonverbal, right? They'll show you, or they'll grind their teeth, right? Radiation, I personally like to say, Milan, take one finger, show me where your pain starts, and then move that finger to where it travels to, right? So you see, he can point to his left shoulder, right shoulder, to the neck. So acute coronary syndromes can go anywhere on the thorax. Could go to the neck, left, right shoulder, right? Go to the belly, to the abdomen. So radiation. Then severity, a lot of books, right? They have a scale 1 to 10. Do not use 1 to 10. This 1 assumes you already have pain. So always use 0 to 10. So 0 is no pain, 10 is the most pain you have ever had. How much is it right now, right? So it says 10, right? Why is this important? Because then we're going to give them some medicine, right? We're going to give them maybe some pain medication, analgesia, maybe we'll give them nitrates, right? Maybe the pain subsides. So I have to document, right, during my transport. I'll say, yo, you told me pain was 10. We gave you some fentanyl for the pain. How much is it now? He said, oh, you know what? It's a little better. Maybe it's 8, right? Time is basically when did this happen? At what time did this chest pain went on? So he will say, you can tell me, what time did this occur?
Got about 30 minutes.
30 minutes ago, right? So we'll look at the clock, right? Right now it's 3:40. So let's say 3:10 p.m. Why is this important? What? Determines treatment, but what determines treatments is essentially your patient assessment and the protocols.
It determines further treatment at the hospital.
Okay, excellent, right? It determines further treatments at the hospital because for this condition, right, if the duration of symptoms is less than 12 hours, right, you're going to take him to the hospital, and what they monitor is not when the person comes into the hospital. They monitor is first medical contact. First medical contact. Who makes first medical contact?
Us.
You do, right? So the moment I made contact, your time starts. So hospitals have 90 minutes, right, to take them to PCI, percutaneous coronary intervention, cath lab. But those places who do not have PCI within them, they have up to 2 hours, 120 minutes to transfer them to a PCI-capable facility, cath lab. If they're not able to do it within that time frames, they got to give them lytics, thrombolytics. Thrombolytics medications that are clot-busting drugs. They will bust clots all over the body, so there's a higher risk, right? With that, there's a lot of contraindications that the doctors have to assess. So this time is very important. They'll ask you, when this occurred, right? If you cannot provide it, they're going to ask your patient about that, right? This is very important, not only for acute coronary syndromes, this is also important for your CVA, right? We determine onset time, less known well, right? To give you an example. And I stands for interventions. Have you done anything, right, to help your chest pain? Have you taken any medicines, right? If the patient says, okay, I took my nitroglycerin, I took my aspirin, or whatever else, or perhaps you're there with firefighters, BLS, they'll say, okay, we gave them 24 milligrams aspirin. Am I going to give mine? So if there's a CFR on scene, gave them 324 aspirin, chewable, right before you arrive, are you going to give yours? No, right? I'm going to document that they administered. I'm going to verify that it's correct medicine, right? But I'm not going to give it. So history of present illness, I want to know what's going on now. Once this is done, and when you guys doing your assessment, please bring a notepad and you're recording this. so that when you are given information, you write this down. So then you could give a concise report, right? Your concise report is, Nikolai, what did you tell me for onset? Was the pain 6 or 10? I'm not sure. Was it radiating? I don't remember. Right? So bring your notepad, jot it down. Right? And then the next thing we do is we're going to do sample history, right? Sample signs and symptoms. So signs are, what are signs? What you see, objective data, right? He had a Levine sign. Maybe he was diaphoretic. Your vital signs are objective. What is subjective? What he tells you, right? He says, I feel short of breath. Oh, I have nausea, right? I feel I have chest pain. Those are subjective. You cannot really objectively assess them. So signs and symptoms, you want to say besides the chest pain, anything else you have, any other problems, anything else you feel. So you could say I have nausea, I have shortness of breath, anything else, right? Do you have any allergies to any medicines, right? So obtaining his allergies. What medications are you prescribed and currently taking? By the way, here's a good question. I come to the call, send this medicines, right? Medicine. Milan says, I take these on the table. I say, you know what? I don't really got the time to write this down. I take my bag, I go like this into the bag, and I take them with me to the hospital. Good, bad? Why?
When they come back, they don't have them.
Exactly. Excellent, right? So what happens is this: when you bring these medicines to the hospital, no nurse will administer them. Why? Because they don't know what this is. They have to be sent to the pharmacy to verify this is the correct medicine. So usually the hospital has medicine, trust me, right? They'll give the patient the medicine. This will sit on the stretcher, and if the patient goes to CT scan or other exam, they'll get lost. Then they'll take them home, right? You know, like a private company, ambulance company takes the patient home. Person comes home, his medication stack is obliterated. He has to go to primary care, get new scripts, go to the pharmacy. You don't want to, have that happen. So write the medications down, right? Take a minute. But if the situation is very critical, like you have to move, if the family member is coming along with me and there's a lot of medicine, I try to write down the most important ones. I'll take the other ones with me. I make sure I give this to the family member and I'll say, you be able to return them? Yes, then only then I take it. Otherwise I don't take it. Right? So only take them in dire situations, and family members not there, I just write down the most important ones. Right? So medications we talked about, pertinent history. So here you would say, sir, any medical conditions you've been diagnosed? For this condition, I'm just going to say, let's just pretend he has coronary heart disease, hypertension, and diabetes. And he had, let's say, knee arthroscopy, knee surgery 6 years ago. Which of these are pertinent to this condition? The first three, right? Because these are high risk factors. That means if he has these conditions, there's more chance of him having, a true MI, right? Good. This is not per se pertinent for this condition right now, right? Last oral intake is the food that he had to eat or drink, and events leading up is basically what were you doing before this occurred, right? So that's your sample. The next thing we're going to go through is this here, secondary assessment. So here you want to do a focused physical exam, focusing on his chief complaint or what he's complaining about. On the EMT level, all you guys did was like vital signs, you were fine. Here it's not going to be fine. So who could give me some examples on a physical exam that I can do to see what kind of problems he may have for his cardiovascular respiratory assessment? Huh? So 12, this will be diagnostics. This is not a physical exam. Yeah.
You could check for pedal edema.
Excellent, right? So I want to check pedal edema. What else? JVD. What else?
Pulmonary edema.
Pulmonary edema, right? So I listen to the lung sounds. I listen to that. What else?
Tracheal deviation.
Tracheal deviation, most likely more in trauma cases, right? But the other more simple ones, I want to listen to the heart sounds. Maybe there's murmurs, right? Abnormal sounds. You could listen hepatojugular reflux for jugular venous distension, right? You want to look at the skin, color, temperature, condition again. So that tells me if he has good perfusion, right? So these are some of the basic things, right, that he may have issues if he has a cardiovascular condition, right? He may have like S3 sound, S4 sound, right? Pedal edema, jugular venous distension, right? So we assess that, and then here, right now, diagnostics. Diagnostics is basically, I put everything together. Vital signs, 12 EKG, 3 EKG, blood glucose level, temperature, anything you want to do, you will ask in your diagnostics. My advice to you when you're doing the assessment, ask for everything. Blood sugar, temperature, 12 lead, 3 lead, everything. Ask for everything. Right. So now, I told you this, right? So we said history of present illness, sample history, focused physical exam, diagnostics. What's the whole purpose of doing all this nonsense?
Paint the bigger picture.
Paint the bigger picture. Can anyone be more specific?
So we could probably treat the patient, you know, with medication to administer.
So before we could treat, what are we going to establish?
Field diagnosis.
Field diagnosis, right? So diagnosis, the word diagnosis means like flowing knowledge. So the whole purpose of you doing all this, you want to establish field diagnosis. So after doing all this, you may tell me, you know what? I think he may have ACS, he may have aortic dissection, he may have pneumonia, he may have a musculoskeletal injury, because all of those can cause chest pain. Then it's your job to narrow it down to what you think is going to kill him now, or what he's having right now. So it means do further assessments, further diagnostics, further questioning. Then you're going to narrow it down to one or two things. The moment we narrow it down to one or two things, I'm going to have to establish, because I have to put them into a protocol. Yeah? So I'm going to then say, you know, for this condition, let's just say, we placed him on the monitor, right? And he was having this arrhythmia. Right, so we see ventricular tachycardia on the monitor, right? So out of all those conditions, he may still have acute coronary syndrome, right? But right now I have a lethal dysrhythmia that needs correction. My advice to you when you guys starting out to doing this assessment, do all this before you give any drugs. So do this entire assessment before you're giving any drugs so you don't make any mistakes. So now we see this rhythm. What I gotta do now?
Establish IV and start.
So before we get
Unstable.
excellent, say it louder.
But determine if he's stable or unstable.
Perfect. Why? Because that dictates our treatment. So we'll go here, right? So stable dysrhythmia is a dysrhythmia not associated with any signs of hypoperfusion. And unstable dysrhythmia is a dysrhythmia that has shortness of breath, hypotension, altered mental status, right? So I used to say chest pain, shortness of breath, hypotension, confusion. They don't get enough perfusion to the heart, right? So that becomes unstable. So for this call, because I want to show you the drugs, let's pretend he has a stable dysrhythmia. So let me go back to the protocol, right? So based on the protocol, right, what drugs can I give him?
Amio 150.
Amiodarone, right? How am I giving it?
IV diluted and
100 ml, or I give him lidocaine, right? So let me show you those actual drugs, right? So you guys can see, so that you have an idea. I'm gonna actually use the watch to show you. So first, I'm gonna show you lidocaine, right? So lidocaine, the dose here is 1 milligram per kilogram up to 100 milligrams. Do we give 100 milligrams right away?
no.
Right? So let's say if he's conscious and alert, I will ask him how much do you weigh, right? So let's say he says in pounds, right? Let's say he says he's 220 pounds, it's about 100 kilograms, right? Then we could give him that. But what if he was 80 kilograms? Are you going to give him 100?
No.
No. You're going to give him 80, right? Make sense? So everybody's clear. You're going to calculate based on his weight. This is a Bristol jet. I'm going to show you how it connects, because if you make a mistake and it's no longer connecting, you're going to have an issue. So these pop off, you probably saw in the movies how they like do this, don't do that. And then it threads. It threads like this. I've been on calls, I've been on codes in the hospital where residents, they don't know how this works and they start jamming this in, right? And when they jam this in, they break the threads. So this no longer threads. This is when it threads, you see, the medicine is going to come out here like that, right? But if I break my threads, the medicine will not come in because the plunger and here the needle does not connect. So if this happens, is this garbage? What can I do? How can I get this medicine out if this breaks?
Extract it.
Huh?
Extract it with a syringe.
Exactly, right? So what you will do is you will take your syringe, connect, right, a needle, and you will basically draw it up. Make sense? Right? So let's say we didn't break it, for the argument's sake. And here I have my Milan's arm, which is connected to the IV. I already established this, right? Notice it's hanging with a saline bag, right? This is my main line. I never, ever, ever, ever mainline drugs through a saline port, ever, right? And the reason why you do this, if there's any untold effects, I want to be able to disconnect this drug and run fluids. What is the main and one of the biggest side effects of any antiarrhythmic medicines? Dysrhythmias, and the other biggest one? Hypotension. Hypotension. Ingrain this in your minds. Hypotension. So what I would do is I put a blood pressure cuff on this monitor, set it at the lowest amount of time I can get it. So every minute, if I can, every 2 minutes. Some of them have every 2 minutes. So I'm getting my vitals cycle every 2 minutes. Yes? You should be wearing gloves, right? And we're going to cleanse the ports. So this is your lower lock port. We've cleansed the ports, right? Let's say he was 220 pounds. We're going to give him 100 milligrams. If he was 80, we said, right? We give him 80. So I connect it like so. And then what I do is I just go like this, right? No? Why not?
So
Slow push.
Slow push.
I got to go slow push. Rapid push causes what? Hypotension. So any rapid push is going to give you hypotension. So what I will do is this, right? You want to close this line. You want to pinch this off so there's no retrograde flow. See how I'm looking at the watch? And I'm going to give this over how much time? 2 minutes. At the same time, my eyes are on the monitor and I'm listening to that blood pressure and those alarms. And hopefully your partner is there to observe the patient, right? And you're looking at the patient as you're giving it, right? You explain to the patient, we'll give you some medicine, right? For your dysrhythmia. And as you're pushing it very, very slowly, observing your time, observing the patient, observing the monitor, looking at the vitals. What happens? BP drops. Stop, right? Disconnect, right? Open my, lower the patient, right? Reassess the patient. Airway, breathing, circulation. Make sense? So this is your lidocaine. It's a sodium channel blocker, right? The next thing we're going to do is amiodarone, right? So amiodarone gets infused, you said, right? Into D5W bag. So here I have saline. This is not the correct infusion. D5W is the correct infusion, right? 100 ml. So just to show you when you grab it. This here, right, it will say when you grab these medications, this will say set, and this will say add. Add, set. What's the difference?
What is medication for?
Which one is medicine? The one that says add. So this is the medicine, the blue one. So the way you're going to do this, right, you're going to take the bigger the gauge of the needle, the faster you're going to drop. So this one is 18 gauge, so it should be fine. How much am I going to drop?
150.
So this medicine comes 150 milligrams and 3 ml.
So 3 ml.
3 ml. I'm going to take the whole thing, right? When you're doing this, I want to show you, even though they're sterile, right, still clean the caps.